on public broadcasting. So please do join us. We're going to have John Abbott, who is President and CEO of WGBH, Andriene Farewell, General Manager of Arizona PBS, as well as the Chief of Staff, Chris Turpin at National Public Radio. Should be a fantastic discussion. So we've now just joined all of our live streaming social media organizations. So let's get this show on the road, and please do contribute in the course of our discussion. Welcome to the Nonprofit Report, your weekly update on nonprofit organizations, issues, and leaders. I'm your host, Mark Oppenheim, and today we'll be celebrating Older Americans Month with a discussion on organizations that support our elders with our special guests, Andriene Iverson, President and CEO of the Elder Care Alliance of the San Francisco Bay Area, Don Simonson, President and CEO of Trellis in Minnesota, and Mark Clark, President and CEO of the Pima Council on Aging in Arizona. And a reminder to Zoom attendees that we'll take 3 snap polls during the show. We'll announce results, and your questions submitted through the Q&A function at the bottom of your screen will be included in our discussions. So thank you all for joining us. We're so happy to have you here to discuss just sort of the important topic that affects all of our families, in fact, and affects all of us. So just sort of to set this up, we're going to go to you, Andriene, first. In 2018, there were 52 million Americans over 65, about 30% of whom were economically insecure. Almost a third of older Americans are economically insecure. And in 40 years, all those numbers are going to double. We're going to have a ton of people who are living in need and who have no ability to earn extra income. So let's talk about your work, how you support older Americans, and especially those of limited means. So Andriene, could you just sort of unpack what you do at the Elder Care Alliance?
Sure. So we are a senior living organization. So we're predominantly assisted living and memory care based here in California. And as some people may know, it's predominantly private pay. And so when you talk about that economic insecurity, you know, we can serve, I always say, about the top 10%. And so one of the things we're really thinking about is how we expand outside our walls to be able to serve a broader socioeconomic group. One component of our business, though, is the Mercy Brown Bag program, which has been in operation for about 30 years. And we feed right now about 8,000 low-income seniors 2 bags of nutritious groceries every month. And so certainly in the pandemic, we've seen that jump exponentially. But we see that growth of elder food insecurity and hunger to be a growing issue, and in some senses, a silent issue. And I think it goes beyond food to also addressing the issues of loneliness and social isolation, which is some of the things we try to do through components of our program as well.
And historically, the United States has really been behind the curve when we look at elder care, partly because of how our society functions. The Great Depression and then the programs that came after really shifted the curve in terms of elder poverty, which was just endemic in the United States and very strongly embedded. It's ameliorated, but as we move forward in our society, how large is the future-looking problem, Mark? When you take a look at your constituents, are you concerned that the curve is bending in the wrong direction at this point, or do you feel like we are headed in the right direction and we just need to accelerate that process?
Well, I mean, that's a great question, Mark. And certainly, I think many things are changing, not the least of which is the impact that this pandemic has had on older adults here in Pima County and throughout our nation and the world. I think there's no question that we need to look at things differently. Issues of economic insecurity certainly have been heightened for older adults. We're seeing a major issue we're seeing here in Pima County is a significant decline in affordable housing, significant increase in rents. We've seen just a very large surge in investor acquisitions of lower cost housing and rents then being increased. So we are very concerned about that. I know as we've been talking with our state and our federal partners and elected officials about issues like that and the pandemic, they're now beginning to talk about the fact that we need to be thinking about this now in a recovery mode. And some of the federal stimulus money we're going to be allowed to spend over a longer horizon than we had originally anticipated. And so we're hoping to be able to begin to build systems where we can address some of those issues. And also, of course, dealing here in Pima County with the local governments as well.
And Dawn, as you take a look at the picture in Minnesota, and Minnesota is simply a microcosm of the United States. When we see issues of elder poverty, they also intersect with other issues: gender, race, orientation, marginalization, mental health. Adrienne was talking about memory retention. So there are various health issues. How do you see the challenges that you face and the unevenness of the distribution of challenge in different communities when it comes to the services that you provide in Minnesota?
Thanks, Mark. We just completed here at our organization an access evaluation. So really trying to understand how Indigenous and elders of color have access to the basic services we fund: meals, transportation, chore, et cetera. And as we were learning more deeply about the current status of older adults, it's very clear that lifelong disparities that affect Native elders and affect people of color just become that they don't go away in elderhood. And when the complexities then of declining health, declining cognitive status then intersect with these lifelong disparities that are present for people, the quality of life for older adults, the longevity of older adults in BIPOC communities is just much reduced compared to the majority population. And so for an organization like ours, that's a funding organization as one of our roles, it's our responsibility to say, how do we target our funds to have a more equitable distribution of those funds, recognizing that people and organizations don't start in the same place. And disparities in Minnesota across the lifespan, unfortunately, are very significant.
You know, it's so interesting. When these organizations started off years ago, 20, 30, 40, 50 years ago, the idea was that we were taking care of one problem set, and it was generic, right? People were getting older, they needed care. Now, we become so much more sophisticated in terms of the individuals and individual needs, and we've had to change the organizations that we've served. We now cannot just hire people or create a board just because they have a skill set in serving elders. There are also cultural appropriately services. There's a way of thinking, there's a way of approaching, there's the idea of how different groups within our society function. Adrienne, what kind of changes have you seen in the arc of your involvement in this sector to modernize your organization?
You know, I think one piece I would highlight is around our memory care program, because I think there is such stigma associated with people with cognitive impairment. And so we set out to look at what philosophies were out there that were kind of best in class. And we ended up partnering with the I'm Still Here group based out of Boston and Dr. John Zeisel. And really it's a shift in focus and a shift in philosophy to say every individual can learn, grow, and contribute no matter their cognitive status and ability. And that is a big shift. And I think one of the things that we really saw clearly through the pandemic is systemic ageism, right, throughout and across our country. And so I think addressing that in the attitudes, the negative attitudes we have about age and aging and our own aging process, which, by the way, have been shown from a evidence perspective to really impact our quality of life and longevity are big issues that we've got to address. So we saw that as a huge change in kind of our culture when we implemented that memory care philosophy. And one of the things we're really passionate about is how do we start to address some of the issues around ageism, stigma, and associated with aging more broadly, not just within our organization.
I love your reference to philosophy. Mark, I saw you nodding in terms of this idea of philosophy and our values, our culture of our organizations. How does that manifest in your environment? Because what Adrienne's saying is not just the technical skill of providing a service, it's about how you think about people and how you think about condition, right?
Sure. Well, absolutely. I mean, people obviously are living longer. When the Older Americans Act was passed, I think people were probably, certainly when Social Security was passed, people were not even living to full retirement on average. And now people are living significantly longer. I know, one of the questions is about people needing to work longer. That I think has actually been an interesting benefit. I've only worked in the aging space for about 7 years, but my predecessor worked into her mid 80s, and as did the guy that was in between us. So our founder worked into her mid 80s. So having an opportunity to be productive and move forward is so important. I can tell you one of the things that I've seen, we've seen, especially around the pandemic, not to harp on the pandemic, but especially around the pandemic, has been access to vaccines has really been completely technologically driven in our community. And I think that's true probably around the country. And that's been a challenge. And I've actually heard people in government say, well, seniors, they just need to get with technology. Well, it's not just a technological fluency issue. It's also a broadband access issue. We hear about broadband access, but frankly, people tend to think of that, I think, in the frame of younger children, at school age children. It's an issue across the lifespan, I guess you might say, and it's an economic issue. So, and then there's just the whole issue of who can afford the technology. So, trying to think about how we deal just with that one specific small point of technology and the attitudes that come with that, I think, have really been heightened in the pandemic.
And Mark, I would just say, Mark, that's such an important point, because there's so much technology now that will enable people to age in place better and longer, right? And at a much lower, price point, so to speak, or cost. And so I think that issue of broadband access and equality is such an important point if we want to really enable a broader socioeconomic group to age in place better longer.
We just completed a poll in which we said, do you or have you cared for an older adult in your family? And 50% said yes, and 50% said no. What I find to be interesting is that it's going to end up being 100%. This is a poll that at any point in time will have its own percentages. Maybe it's 50%. But it will end up being 100% because we're all going to get older, and eventually the person that we care for will at the very least be ourselves, right? So this is an inevitable problem. And if we have limited income, then having that income trickling through our fingers in terms of broadband connection costs on a monthly basis, there are sometimes some really difficult decisions to make. You might not have access to broadband because you need to spend your money elsewhere, right, Dawn?
That's right. And I think one of the costs really that we need to continue to try to drive down for older adults are healthcare costs. So our gaps in Medicare are still very significant, including gaps in coverage for drugs, for new drugs, for basic drugs like insulin. So the out-of-pocket expense for older adults for uncovered drugs or drugs that are partially covered, or to pay for those Medicare supplements or Medicare Advantage plans, really require quite a bit of monthly income to go out the door for an older adult to maintain their health. And I think that we know that if older adults can access preventive services, primary care, high quality, timely, acute care, that not only is the right thing to do for older adults, but it also will help our overall spend on healthcare because, I think we believe that we will have healthier older adults, fewer older adults that require premature institutionalization, better quality of life. And so this need to continue to drive down healthcare costs for older adults is really critical.
We're going to launch a poll that is about exactly this topic, about to what extent we should be investing in care for older adults. It'll be very interesting to see how people respond. If you look at this healthcare cost issue, so often our healthcare system, the costs of it are justified in terms of the development of new drugs, which benefit us all, and certainly older Americans. Do you believe, in terms of your constituencies, that the costs, the return on that cost investment, keeping drug prices high so that new innovations can be funded by private companies, is that worth the return on investment, which is basically the question that you're begging, Don? Let me give you the first cut at that, and then we'll go around to Mark and to Andriene. Is that worth the price of the high cost of drugs?
I mean, I think we have to say that we want to be a leader in this country, right, in developing new treatments and drugs, including to slow the onset of Alzheimer's and other dementias. But there are other reasons that drug costs are high, right? There should be no reason that an older adult that has a supplement to Medicare or an Advantage plan to Medicare might pay $200 a month at a certain pharmacy for the very same drugs that they would pay $10 a month for at another pharmacy. So there are all these complexities in our system of distribution and availability of drugs and coverage and formularies that are often just unknown to the average consumer, and they spend more money than they should. And for basic drugs like insulin or inhalers or other drugs that have not been as expensive in the past and are so now, that doesn't equate for me relative to your question in terms of costs of investing in new drugs and new treatments.
So what you're saying is that there are so many drugs where the innovation happened decades and decades ago, and these are just basically generic drugs at this point. The cost should be low, transparent, distribution should be pretty much automatic, accessibility should be general. And what you're saying is that you could absolutely improve the situation considerably just by that act. Am I understanding that correctly?
That's correct. And I think that would be a very consumer-focused, consumer-oriented actions that would, I think, older adults would appreciate. And I think the sad part of it is that many older adults right now just don't realize that there are some things that they could do to control their medical costs related to drugs, and they are just completely unaware of what that might be.
Mark, how do you see it?
Well, I think it's very similar. I mean, we do a lot of work talking with Medicare beneficiaries in our system, as I'm pretty sure Don does as well.
Right.
And we had several, maybe 2 years ago, we had a woman come in and she had a $10,000 she was paying in Part D co-payments, the drug benefit and co-payments and premium costs that somebody had sold her. An agent had sold her that policy. We sat down with her. She couldn't afford it. We sat down with her and actually ran her drugs through the Medicare computer, which anybody could do on Medicare's website. And we found her a policy that was going to cost her $2,500 a year in terms of premium costs and copays. So there just is, because of the way the system is structured, there are many opportunities for costs to be incurred. And sometimes, you know, I know I was for a while on an old antibiotic that was a generic, but only one company was producing it at that point in time. And so they tragically jacked up the prices. Had nothing to do with development. It had everything to do with the return on the owner of the company's, investment. And it isn't like I don't believe in, the fact that people ought to be able to make money. And clearly, I think there's no question older adults want choice. But there also is just a huge amount of demagoguing that's going on in the market related in the world related to healthcare costs and return and the expenses.
This is in part a question of our own human values. It seems to me that there is a part of capitalism where we just feel like we should be able to get whatever we can get. So the person who sold the $10,000 policy to your older client, they didn't think they were doing anything wrong. They made a sale. They made the most money they possibly can. But do we need to combine this idea of capitalism with this idea of taking care of each other? In other words, this idea of community. Andriene, you talked about the whole idea of helping people who might not have all their facilities as they age. And it seems that elders are very often exploited for that fact. Do we have to shift how we think about this, and then also create sanctions that specifically target people who are taking advantage of your clients who need help from us all?
Yeah, I mean, I think it goes back to that underlying topic that I spoke to earlier around ageism, right? And our own personal perceptions of age and the aging process. And do we value older adults and the contribution that they can make to our communities and society or not? And I think we've got to have some explicit conversations about what our real beliefs are about older adults and the contributions. I think the two other points I would make relative to the drug issue is, I think one of the things that is so encouraging coming out of the pandemic is that there was unprecedented collaboration and government support, right, of the vaccine development. And you can see what that does in terms of speeding up that timeline. And so the other pieces, there's at least one company that I know of out there that's utilizing artificial intelligence to really shorten the drug design cycle or production cycle and get a higher hit rate, right, on those drugs that are effective. And so I think there's some things coming down that will help us reduce the cost to produce drugs. But I think the last thing I would say is, if you look at the Netherlands, the per capita spend is pretty comparable to the US, except a much lower percentage of it is on healthcare. And we are very healthcare, medical, drug focused and not home and community-based services focused. And when I think about older adults, particularly older adults with cognitive impairment, if I've got a disease, the medical system knows how to handle that. If I have dementia, there's not a lot of supports. And we've got to be thinking about how we shift dollars away from healthcare and the medical system and more to home and community-based services. And there's a way to do it where you get better outcomes without the spend.
Go ahead.
I would just say completely support Adriene's position. And I think there's good work happening across the country where there are new models where healthcare organizations and aging services, social services organizations are addressing both the healthcare and the social needs of older adults in ways that do result in better outcomes. But the revenues have to follow so that the services delivered by the nonprofit social service community, those services must be paid for in full.
It's such an important point. What you're basically saying is that the elder care system's revenue model is one that generates revenue so that it can flow to drug companies and medical care providers. right? That's the revenue flow, right? And what you're saying is that actually too much of that flow is flowing into the hands of private interests that are attached to the medical community and medical care and drugs, and not enough is flowing into the social, psychological, and well-being needs of older Americans in this country. It's a very interesting point, right? It's the intersection of commercial interests and our caring workflows. And maybe our caring workflows should be adjusted to provide a more balanced provision of care for older Americans. Mark, we just completed a poll in which we first asked whether Social Security should be retained in order to help elder Americans. 100% people said yes, so that's no surprise. We're doing a poll right now which is really focused on where people see the largest problems that people confront. We're going to go around the table one more time because we're coming to the end of our time. And let's talk about, Mark, what you think the biggest, most impactful act we could take to improve the lives of your constituents on a national and local level. What would that be?
Well, I think it sort of builds on the conversation we were just having, and that's this concept of social determinants of health, which we know have a huge, much larger impact on people's longevity and health than does spending on medical care. And that's food security, employment, income, housing, behavioral health, all of those issues. And so one of the challenges, which I think Don was alluding to, is that the healthcare system has been very slow to come to the realization that if they in fact support those kinds of services or the justice issues attached to them, that they'll be spending less money on caring for people with significant chronic health conditions. And so trying to do that, that's number one. And then number two is the workforce issue, especially the direct care workforce issue, is a huge issue for us.
And Dawn, what do you see as the major change that ought to take place?
I would build on what Mark said, and it's not only the private healthcare system, but it's also our Medicare program, right? Needing to be certain that Medicare resources can be spent on social services. So I would add that. And
Andriene, we'll give you the last word. What do you, if you could wave a magic wand and get Congress to all hold hands and sing songs together, what would you like them to do?
Well, there'd probably be two things on my wish list, and one is similar to what Don surfaced, which is a reimbursement model that would actually focus on maybe an evidence-based well-being measure as opposed to services or a healthcare outcome. And the second is something Mark surfaced, which is if you look at unpaid caregiving hours, I think it was like 18.4 billion associated with people living with dementia. And I think about our team members who they themselves go home at night and are caring for one of their parents. And so there's got to be a recognition for the family caregiver and how do we have supports for them. And so that would be the other piece that I would want to tackle.
And our attendees voted as well. They voted for two issues. One is the healthcare system is difficult to access, difficult to navigate, lacks transparency, expensive, is inefficient. That needs to be simplified according to our attendees. And the other piece is the lack of available in-home supportive care. In other words, it's very much the human non-medical piece, the social interaction piece. So our attendees seem to echo the kinds of input that you're providing. I'd like to thank you all for sharing your experiences and for your wonderful work, the work of your boards, your staff. You're so important. And when we think about the fact that we have a huge, huge part of America that lives in insecurity and need, and the work that you're doing is so very important. Thank you for sharing your work with us, and thank you very much for your insights.
Thank you.
Thanks, Mark.